Good afternoon, everyone. We're just waiting for a couple more people just to join. Great. So a very warm good afternoon to everyone and welcome to our SA Child webinar, where we will be discussing feeding challenges in children with neurodisabilities. My name is Jackie Bezadenhout and I am a developmental pediatrician from Charlotte Maxeke. I'm also a board member at SA Child, and joining me as co-host today, I have Isaac Mulaudzi, who's a medical doctor from Limpopo and also board member of SA Child, as well as Gillian Salugi, who is our chairperson of SA Child and a physiotherapist. Before we start the session, I would just like to remind everyone that this session will be recorded, and we encourage you to make use of the chat function to post questions, because once the panelists have done their presentations, we would love to engage with some question and answers and have discussions around any clinical aspects or challenges that you have experienced. So today's session is one that is close to everyone's heart who works in the field of neurodisability. Feeding is a vital part of our survival as human beings and is associated not just with nutrition, but also with socialization and enjoyment. However, for some children with feeding challenges, it can cause significant stress to the families, as well as have serious health complications. So we are very privileged today to have a panel of experts join us to explore some of the management options of common oro-motor and gastrointestinal disabilities. It does take a team approach when dealing with these challenges in practice. And so we have invited some key team players to join us this afternoon. Each one of these experts are experts in their respective fields and are all involved in the care and management of children with neurodisability. So first, I'd like to introduce in our panel, we have Manaz Karim, who is a speech therapist and audiologist who has worked in both the public and private sector and is currently completing her MSc in neurodevelopment at Wits. We then have Dr. Tim de Maayer. I don't know if you guys want to turn on your cameras as I come to, we've got Manaz and then we've got Dr. Tim de Maayer, who is the head of the Paediatric Gastroenterology units at Rahima Moosa Hospital in Johannesburg. We then have Dr. Taryn Gabler, who is a pediatric surgeon who is currently working in private practice in Johannesburg. Welcome to you guys. And then we also have Lucinda Lourens, who is a dietitian who's currently working in private and has a master's degree in cerebral palsy. Our fifth panel member is Isaac Mulaudzi, who is representing the other vital member of the team, and that is the parent of a child with cerebral palsy. And so we would like to kick off the session by inviting Isaac to start with sharing his experiences, being a parent as well as a medical doctor, and having a child with cerebral palsy. So Isaac, if you would like to unmute yourself and share with with all of the guests on the webinar what it has been like and the challenges that you encountered with your daughter Monet and some of her feeding challenges.
Okay, thank you. I'm Isaac Mulaudzi from Limpopo. I'm a medical officer in one of the rural hospital, Salem Hospital. As during this time, it's a load shedding time. I'm presenting from my car because I'm trying to get area where I will get good connection. I am a father of a child who's 10. You know, men are not good with numbers. I think she's 10. She was born in 2012.
Dear, we seem to have some connection issues with Isaac, who, as he mentioned, is currently in Limpopo with some connection struggles there. I wonder then if we could maybe come back to Isaac.
Oh,
sorry, Isaac, we lost connection there. If you could maybe just repeat that.
I said from birth we had a challenge with the child. She was having poor sucking reflexes. Then having that challenge, we were assisted by the speech therapy in a hospital in one of the hospitals in Johannesburg. Then we were traveling on a monthly basis to Johannesburg to access the service. Not that in Limpopo we were not having the service, but fortunate enough, during the time of birth, she was delivered in Gauteng. Then we managed to have the MDT team around Gauteng that were assisting us. Then it forced us to travel from the first year of age up to the 6th year when she was graduating from the child CP clinic to join other clinic. Then she was having difficulty with sucking, and sometimes when she's sucking, some of the food or the milk, they were drooling by the corner of the mouth. Then when the child was growing, we weaned off from the milk at the age of 6 months. That way we're starting to introduce soft porridge. She was having difficulty with swallowing of those soft porridge. Then training proceed with speech and other MDT members. Then now, to cut the story short, is the child who's eating everything. The family food that we're eating, she eat. She can chew the meat. She can eat the burger. She can start, she can finish a Big Mac. Like she can start it from the beginning. We don't chew first to give her the direction. Then she can chew, but unfortunate, because she's full paralyzed upper and lower limb, she can't carry, we had to feed her. The other challenge that we are having, when she's feeding, some of the food, they spill off the mouth, but we're trying to manage. Then she's having a problem with drinking. When it comes to drinking, always when we try to give her drinks with a cup, she end up wetting the whole body. Then we come to a point that we try to use squeeze bottle. From the time that we started using squeeze bottle, she can drink nicely without wetting herself. She can try to.
Sorry, Isaac, it appears, okay, you've muted.
Can you hear me?
Now we can, yes.
Yeah, I was saying she can try to hold the squeeze bottle cap with the mouth, and when you squeeze the drink, she can drink properly. The only challenge is that she can't drink with a cup because the food spill at the side of the mouth. Then I don't think she's having a challenge with swallowing, because she can swallow, she can eat food without being mashed. She can just eat a meat the way it is. We don't mash food for her so that it becomes very soft. She can chew, she can swallow nicely, but the only challenge that we're experiencing, I think, the reflex on the mouth to carry food, the amount of food within the mouth so that they can spill. That way, I assume that it's a challenge, but it's a child that is attending a CP clinic. She's being seen by OT, dietitian. They are prescribing food for her. And she likes a lot fatty food, like junk food. It's a person who likes things like burger, meat, and all those stuff. We don't have a challenge feeding her so far, but it's a child whom we experience it from the beginning. From birth, we thought that there's a challenge with sucking reflex. So that's when we pick it up, or she can't suck properly. And when we diagnose a CP, it started with a jaundice, then it ended up being characterized that leads to a full complete CP. The child can't sit, the child is always lying, but we are using the chair called Madiba Baki for her to sit. So yeah, that's all I can say. If you can put things on her hands, because the hands are stiff, she will grab the thing and try to take it to the mouth. Then, but it's difficult for her to feed herself. But like a stock sweet, I can give her stock sweet, put it on the hand, she will put it on her mouth, try to chew it. Most of the food that we give the child, the first thing that she wants to do is to chew the food. That's why even the cap of the squeeze bottle that we use, we're always changing the cap because she tried to hold the squeeze bottle firm with the teeth to a point that it damages the cap. Thank you.
Thank you, Isaac, for sharing that. It must have been, or maybe you could just also just say what it was like being a parent and a medical doctor. So obviously having that knowledge, but then experiencing it firsthand from the parent's perspective, having a child with such severe challenges, both neurologically and then with feeding.
Okay, as a parent, yeah, it's not a simple thing because most of the time you have to do things for the child. So for me, I'm coping because I can manage to get other people to help me. We welcome the child, we love the child. We give ourselves, as a parents, we give ourselves time to take care of the child. The child is attending the school. After school, we know every time when she comes home, the helper has to feed her first. At night, the helper has to feed her, and the child can even show us the signs. When she's hungry, she can even mumble to tell us that she's hungry when she wants food. She can mumble when she's thirsty, that she wants drinks, to a point that we have picked that sign as a parent and as other caregivers, so that we'll assist the child as soon as possible before the child gets more severe hungry. But we try by all means to keep giving her food on time rather than to delay giving her food.
Thank you, Isaac. I would now like to move on to Manaz Karim, who, as I mentioned before, is our speech therapist. And Manaz, if you could maybe just introduce the EDAC system and then a little bit about your role as part of our vital member of the multidisciplinary team. Thank you.
Okay, can you see this? Hey, Jackie.
Yes, perfect.
Okay, all right, okay. So I'm going to be talking about the EDACS, which is the Eating and Drinking Ability Classification System. Sorry, I'm just having trouble. Okay, I'll just talk while I try and get this.
Do you want me to share from my side, Manaz?
Yeah, if you can, because
Yes,
it's
sure.
not changing screens. Okay. So the EDACS, or the Eating and Drinking Ability Classification System, was developed as a tool to classify the eating and drinking abilities of children with CP. So it's a 5-level system, and each level essentially provides a broad description of the child's functional ability, which includes motor and sensory aspects. And in addition, it also indicates the level of assistance required by the child to eat. So as Isaac mentioned, his daughter eats quite a variety of foods, but that she is quite dependent on somebody to be bringing the food to her mouth. So she would then be classified as somebody who's totally dependent. There's also a level called RA, which requires assistance, and then somebody who's actually just independent. So in terms of the scale, it focuses on the functional abilities during functional feeding tasks. So that would be tasks like sucking, chewing, swallowing, and then keeping food in the mouth. And Isaac actually gave a really nice description of his daughter's eating and drinking, because he spoke about her difficulties with sucking, that she's able to actually bite and chew really nicely, but that she does have some difficulty with keeping food in her mouth, especially with liquids, because there is some drooling then from the side. So it's again important to note that the EDEX is not necessarily an assessment tool, but rather that it's a descriptive measure of whether children are able to eat and drink safely, and that is without aspiration or the risk of aspiration, and then also efficiently. So efficiency with regards to the EDAX refers to, what is the duration of the child's feeding, or how long does it take a child to feed? What is the effort required for this child to feed? And then, going with effort, how easily does the child tire? So, are they able to complete a meal, or are they fatiguing sort of 10-15 minutes into the meal and they haven't even gotten through the bulk of the meal as yet? And then it also talks about oral spillage, and that would then be loss of food. Loss of food and then liquid. And then just again with regards to efficiency, efficiency also describes sort of the different aspects of the mouth. So your lips, so in terms of lip closure, are you able to have lip closure? And lip closure will actually prevent food from spilling out. And then he also talks about the tongue. Do you have a tongue thrust, which again pushes food out of the mouth? And this essentially impacts on the amount of consumption, which then impacts on nutrition, growth, and hydration. So if we're looking at the EDEX level, so it's an ordinal scale basically with levels 1 to 5. And if we're looking at a child who's on level 1, we're saying that the child on level 1 eats and drinks safely and efficiently. So descriptively, what this means is that this child will eat a wide range of different textures that are age appropriate, but they'll also eat and drink at a similar pace or speed to that of their peers. Children also have good or adequate oro-motor skills in that they are able to move food from one side of their mouths to the other. And in terms of a sensory aspect, they are able to feel that there is food residue in their mouths and then clear their mouths. Although children on level 1 may still gag with more challenging textures. So especially if a texture is new to them, they may then gag. With regards to your child on level 2, a child on level 2 will eat and drink safely, but will have some limitations then to efficiency. So this child will then still eat a wide variety of textures, but their oro-motor skills are then slower. So while they're still able to move food from one side of their mouth to the other, the pace is slower. They will also find some textures are more challenging than others. And because of this, meal times then will be longer. And then again, there'll be small amounts of oral spillage, and this is often due to an oro-motor skill, and there will be some food residue left after a swallow. And a child on level 2 may also cough and gag on a thin liquid, and then also on a texture that's new. So they find, the thin liquids a little bit more challenging. Your child on level 3, so your child they'll also tire easily if the meal that they are eating requires quite a bit of chewing. In terms of liquids, they prefer thicker liquids over thinner liquids because your thicker liquids are often better to handle and to cope with rather than a thin liquid, which is actually quite runny. And you'll often find that your children on level 3 will also only choose to be fed by specific people. So often you'll find that, your parents or caregivers, if you ask them how many feeders or who's able to feed the child often has like limited members in the family who are able to feed them. And this is because you really need to know the child well in order to, go by the child's pace with eating and drinking and know how to present either the food or the liquid to them. So your child on level 3 may also aspirate or cough on liquids, and this is mostly on thin liquids. And you'll often find that there'll be residue after the meal, and this residue will often be either behind the front teeth or on the roof of the mouth or on the sides, which we call pocketing, which would then be in the cheeks. If we're going to level 4, level 4 describes a child who eats and drinks with significant limitations to safety. So this child is mostly or only having very well mashed or smooth purees. They are really challenged by foods that need chewing. And if they are presented with a lumpy piece, they often swallow those lumps whole, and this then leads to gagging. Oro-motor wise, their oro-motor skills and their motor coordination is actually quite poor. So they have difficulty coordinating what we call the suck, swallow, breathe pattern. And, you know, during the meal, because of this incoordination, they will often show signs of aspiration, which could come across as either nasal flaring or difficulties with breathing. And again, because of coordination, they are unable to, you know, open their mouths, either in anticipation of the approaching spoon or the cup, and then coordinate that with either biting or chewing or swallowing. And again, they often have primitive reflexes. So there'll be a lot of tongue thrusting or phasic biting, and this then often leads to quite a bit of oral spillage. And this then leads to prolonged meal times. So in effect, it's all like a domino effect. The poor oral motor skills will then also mean that they will often swallow multiple times to clear one bolus. So again, this contributes to prolonged meal times. And then they also need time in between each mouthful, and often that's to recover with the breathing because of the suck, swallow, breathe in coordination. So your child on level 4 will require positioning, making sure that they are positioned optimally for the feed. They also required skilled caregivers, somebody who's able to feed at their pace and know which consistencies that are high risk for them. And they also often need modifications either to the utensils or to the food. And because of this, feeding is not always efficient sometimes. So we also then consider tube feeding for children who are on level 4. And this is mainly also, other than to reduce the risk of aspiration, but also to assist with hydration, nutrition, and growth. Then if we're looking at your child on level 5, children on level 5 really have challenges with eating and drinking safely. So they are mostly unable to eat and drink safely, and there's often very glaring signs of aspiration and choking during meal times, and the oral motor skills are actually quite poor. So there's also, you know, that coordination that's not there in terms of mouth opening, and again, coordinating the sucking, the swallowing, and the breathing. These are also often your children who will have persistent or chronic aspiration pneumonia. And we then highly consider tube feeding for children on level 5, although we do try and encourage and introduce small oral tasters, just so that we are still maintaining some level of oral motor skill. Yeah. So if we're looking at what is a speech therapist's role in eating and drinking, and I often get asked, and especially in the NICU, you know, when you're called to see a baby for feeding, why are speech therapists? Yeah, what are we doing with feeding? And why is a speech therapist necessary? So the speech therapist's role in eating and drinking, I think firstly is to assess, you know, the eating and drinking of all children, and then to determine safety and then efficiency of each consistency. So depending again on the age of the child, because our goal is always for age appropriate management, so, or age appropriate skills. So we will then determine safety and efficiency of each consistency. So a thin liquid, so for instance, that would be something like milk, and then you get what we call a semi-solid, so that would then be a mashed food or a puree texture, and then something solid, which then could either be a burger or a biscuit or a cookie. So we assess each consistency and then we identify what is the nature of the feeding difficulties. So is the difficulty because of is it a motor difficulty? So is it because of oral motor skills? So is it a tongue thrust? Does the child have poor lip movement and is unable to obtain lip contact? Is there poor jaw dissociation? So are they opening their mouths too wide or are they opening too low? And then do they have poor tongue movements in terms of trying to control the bolus in their mouths, which either would lead to oral spillage or that the food running down to the back of the throat and then causing coughing and choking? Or is it a sensory reaction, which is basically either a hyper or a hypo reaction to food and new textures? And this could sometimes, if the child was hypersensitive, lead to gagging and vomiting, which could be excessive, or just being hyposensitive, where the child doesn't actually realize that there's food in their mouths. And then just to identify what type of feeding difficulty it is. So, feeding or the swallowing has 3 or 4 phases. So we're looking at your oral phase, which is basically where your oro-motor skills come in. So that's things like, lip contact. Are you able to suck? Are you able to, cup your tongue so that you can control milk or food or something runnier in your mouth, and then transport that, or what we call bolus manipulation, to the back of your mouth, where your pharyngeal phase actually kicks in, and then that is your swallow. So, do you have a weak swallow where you are only able to swallow little bits of the bolus at a time, or can you swallow in one go? And then are you coughing or choking or gagging, or then aspirating? And then your esophageal phase, which is basically then reflux. And how is this then impacting on your feeding skills? And I think once we've determined, where the difficulty lies and in what phase, we then design an individualized intervention plan to meet the needs of the child and the family. And, this individualized plan means that it's not a one-size-fits-all plan. So you have to, really just identify, what is the family's meals like, and then almost assess based on that. And then just to also say that feeding is not something that's stagnant, and it changes over time. So there has to be constant assessment and management as you almost manage the child. You're constantly assessing for any changes with the feeding, and that it has to be multidisciplinary, because you are then looking to your dietitian for assistance with thickening feeds, or for assistance with supplementing the feeds for growth and hydration, or you are looking at your gastroenterologists, your pediatricians, and your surgeons for assistance with medication for reflux, or for assistance with surgery if the child needs either peg feeding or a Nissen to assess for reflux.
Thanks, Manaz. I think if we can leave the questions for your section after everyone has presented, then I can just allow our other speakers just to present from their perspective on the multidisciplinary team. But thank you so much for sharing the EDAX with us and your role as the speech therapist on the team. So if I could then ask Dr. Tim de Maayer to share a little bit from your side as the pediatric gastroenterologist.
Thank you, Jackie, and thank you to Jackie and Jillian for inviting me. I want to get this into presentation mode. Okay, maybe I should start at the start. Good. So my name's Tim. I work at Rahima Moosa Hospital, like Jackie said. I've been a pediatric gastroenterologist for 8 years now. And one of the things that we enjoy very much is our multidisciplinary gastrostomy feeding clinic that we have once a month at Rahima Moosa. And sorry, I think my slides are a little bit mixed up. So the few things I wanted to mention to you is, how do you assess nutritional status in children with neurological disabilities, and especially in children with cerebral palsy? who might have several contractures and that sort of problem. Also just want to mention how we calculate nutritional requirements and how we go about that. And then two topics that are often found in these children is they get a lot of reflux and they get a lot of constipation. So I'm going to touch on that as well. So like I said, we've got an excellent multidisciplinary team at Rahima Moosa. I'm very proud to be a part of them. I think probably we are the least important of this group of people that are suggested to be part of your feeding clinic. And just a background, pediatric gastroenterology is a relatively young subspecialty, but essentially our subspecialty covers gastroenterology, hepatology, and nutrition. And as part of nutrition, we often are the technicians to put in the pigs and that sort of thing, but I'm going to leave all of that to Taryn to tell you about. So to start off with, assessing nutritional status in a child with cerebral palsy is fraught with problems. So
I'm sorry to interrupt you. On the screen share, we just seen the recommendations for nutritional assessments.
Oh gosh,
I'm not sure if this is the PowerPoint that you.
No. So what I'm gonna stop sharing and then I'll reshare because.
Okay, super. Thanks. I'm sorry to interrupt.
No problems. What do you see now, Jackie? Same slide.
No, that's exactly what you shared before. No, this is the right one. This is the correct one that you'd shown me before. So super. Thank you so much.
Sorry about that. Okay, so I've mentioned what we're going to talk about. I've mentioned our multidisciplinary team. So just to talk about assessing nutritional status, several studies have shown that weight for height actually is a pretty useless measure in children with neurological impairment. So, and several studies have actually shown that a significant group of children, I think it was 40% of their children that were severely fat depleted, were not diagnosed if you just used a weight for height less than -2 z-scores. In addition, height and length is obviously not always possible, and we sometimes use proxies to measure like heel to knee length or ulnar length and that sort of thing. But it's not always available to us to measure that accurately. So I think MUAC for age is a very good thing to look at in children with disabilities. You do have to plot it. You can't just use the standard cutoffs for malnutrition, but it tends to be quite good at identifying both lean and fat mass depletion. So there's several CP growth charts, which I'm sure you're all aware of. The issue with the CP growth charts is that every child with CP is different. And some of the charts try to account for this by, again, putting children into different classes, and more severe classes are thought to grow less than the less severe ones. I think one criticism has been that we really want children to grow as they're supposed to grow, as normal children. So looking at a population that's possibly malnourished is not a great way of comparing your child. So CP growth charts, I think, are on the way out. Fat mass. By the way, what I'm talking today is really recommendations from the ESPGHAN guidelines. ESPGHAN is the European Society for Paediatric Gastroenterology. And in 2017, they put out these guidelines on the feeding of children with neurological impairment. So they feel quite strongly that triceps skin fold should be measured at each and every visit And it's a great way of assessing the fat mass. And I think we do have several children that have developed overnutrition and obesity. So this is a good tool to use. Where you've got access, they also recommend annual DEXA scans to check the bone mineral density, and obviously you need to address that as needed. And then some blood tests that can help you is looking for the micronutrient deficiencies that we often see. So nutritional requirements, the recommendation is still to start off with this Schofield equation, which calculates your basal metabolic rate and has been shown to be more accurate than some of the proposed cerebral palsy calculations, which tended to overestimate energy requirements. So this is a standard formula. You plug in the weight and you get an answer of whatever kilocalories they think the child's spending per day. And then usually we apply a physical activity level factor to this. So we multiply this resting energy by a certain number to estimate our total energy expenditure. And in most children, this is 1.5 or 1.6 times the resting energy expenditure. But in children with cerebral palsy, it's usually closer to 1.1. So we've got to take into account that there's a lot of factors that contribute to this. Is the child mobile? Is the child in a wheelchair? Does the child have spasticity? So sometimes spasticity does add a little bit of energy expenditure, but it still doesn't reach the amounts that normal children will require. If you can do body analysis, body composition analysis, then addressing or calculating the energy requirements on lean body masses is more accurate. But generally, they would start with a Schofield equation, and then they would monitor the response and the growth and adjust from there. So given that you're not going to have a very accurate measure using this equation. Proteins generally normal intakes for age. The only reason you would increase it is if there's bed sores and ulcers to improve wound healing, or on a child who's on a very low calorie diet where you have to make sure that they get adequate protein intake to make sure that the brain development that can occur will occur and there's no shortage of substrate. And then lastly, I think we often forget about the macronutrient deficiency. So a child who's taking in a lower amount of calories per day is also going to take in a similarly lower intake of micronutrients. So recommendations are to check regularly, and where you can't check regularly, when you can't do blood levels and that sort of thing, maybe you should just supplement to make sure that you're not missing out on macronutrients. Okay, so two issues that we frequently see in children with neurological disabilities. The first one is quite controversial, and I suspect that Taryn is going to tell you that everything I've said is wrong. So this is my take on it, and it is very controversial, and it's a topic of ongoing study, really. So reflux is basically the passive movement of stomach content into the esophagus, and it occurs frequently in children with neurologic impairment because they may have delayed gastric emptying, delayed motility or slow motility. They also have problems with posture, so they're more likely to get reflux as a result of that, often have increased intra-abdominal pressure because of spasticity, etc., and spinal abnormalities. So we see lots of reflux. So the first thing is that a trial of PPI is a perfectly acceptable step in managing the child with respect to reflux disease. If you've got it available, pH and pedant studies can help you show how much reflex you've got, what pH of the reflex is, etc. But it's not necessary before you try a PPI. And then gastroscopy, I think our personal experience here at Rahima Moosa is we frequently do gastroscopy to put the gastrostomy tubes in, and the prevalence of reflux esophagitis and gastritis actually in children where we put a peg is very, very high. In fact, just this Monday we had a child with severe reflux esophagitis on his scope, so he's gone on to a PPI. Contrast swallows. So the pediatric gastroenterology literature will tell you that it's only useful to detect anatomical abnormalities. So if you're worried about a hiatus hernia or malrotation, you should do a contrast swallow. Seeing reflux on a contrast swallow really means nothing, so don't do it for that reason. They also don't recommend doing a routine contrast swallow before peg insertion, although I think the surgeons have a different view of that. So yeah, each center will differ. And then milk scans, I think we don't use them properly. So milk scans are most useful for looking for aspiration pneumonia. And to do that, you really should do a delayed film or a delayed picture about 24 hours after eating the radioisotope. And if there's still some contrast in the chest, then you know that isn't supposed to be there, and that's a sign of aspiration. In terms of treatment, so the lifestyle changes, as we say, thickeners do help children. Blenderized diet, so I'm very pleased that Lucinda is going to tackle this topic at length. It's a very hot topic. Blenderized diets have been shown to improve the incidence of reflux and constipation. And yeah, I think I'll leave that to her, but it's essentially a home diet blenderized rather than using formulas or pre-prepared formulas. Okay, then we already said we like PPIs. Baclofen tends to reduce reflux. So in children where baclofen is indicated, that might help. And then the safety of prokinetic drugs really hasn't been assessed in children like in children with cerebral palsy, let's put it that way. So the recommendations are, don't use it as a first line. If you're stuck, you can try it, see if it helps. If it doesn't, you might need to call your friendly surgeon, and they might need to put a jejunostomy tube or a Nissen if they're not responding to your conservative measures. So then lastly, constipation. I've included our lovely Bristol stool chart, which is very helpful. And again, the sort of contributing factors to this are the child's hypotonia, the immobility, so not moving your trunk is a cause of constipation. And then we also have dysmotility in some of the children with neurological impairment. So one is it's a clinical diagnosis. I still see lots of people doing x-rays and even sonars for constipation. It really is mostly on history, I would say. Abdominal exam and rectal exam. Don't not do it because it's a child. Might make an easy diagnosis of constipation. In terms of the treatment, in private, you would use polyethylene glycol, so that's the Pegicol, the Merdicols, Forlex, that sort of thing. One point I want to highlight is that I frequently see tiny doses of PEG given, and the disimpaction dose is 1.5 grams per kilo per day. The pediatric sachets only have 6 grams in them, so if your child is more than 4 kilos, they're going to need multiple pediatric sachets, or you can use adult sachets, which have got 13 grams in them for not much more money. And then maintenance dose, you drop by half and you sort of titrate to response. An important thing to remember, if you've got aspiration, you should not be using polyethylene glycol, nor should you be using liquid paraffin as a treatment for constipation because of the pneumonitis that can result. Lactulose is a safe alternative that we use in the States. Again, often underdosed, so you need to make sure it's a decent dose. Diet and fluid intake are important, but by themselves, they're not going to cure constipation. And then there's several surgical procedures that you can consider as a last resort. ACE is the antegrade enemas, where the surgeon creates a tract into the cecum, often using the appendix, which you can then use to flush the stool out using a bag of normal saline or whatever. So I think that is what I wanted to say. In terms of this picture from a 2019 publication from ESPGHAN, I think Manaz has covered the top half. The bottom half, we're going to debate with Taryn, but essentially the recommendation would be to, if you've got reflux, to first try and control it with a PPI and diet, and then do a gastrostomy if the reflux is improved. If your reflux is severe, but this is controversial, you may consider going straight for a gastrostomy with fundoplication or a jejunostomy, but I'm sure Taryn will tell us more about that. So that's all I had to say. I'm happy to answer questions later.
Thank you so much, Tim. That was fantastic. Yeah, as we said, we'll do questions at the end. So if I can now ask Taryn, Dr. Taryn Gabler, our pediatric surgeon, to do her presentation. Thanks so much, Taryn.
Thanks. And like Tim said, thank you very much for having me. I am so pleased to be here. I'm going to try and share my presentation, which I must say, open system preferences. Jackie, do you have my presentation as well?
I do, Taryn. Do you want me to share?
Please, yeah, I can tell you now if I try, it's going to take all day.
No, let me grab it. Okay, I just want to get to...
Thanks.
So let me just get to slideshow. Okay.
Yeah, so I think Tim was very kind when he called himself a technician. I absolutely agree with that, although I think he's got a lot more on the brain side than we surgeons generally do as far as the technician point is concerned. And I often tell my patients that I'm just the plumber. So when we look at feeding access for children, like Manaz was saying at the beginning, generally we're talking about the kids have level 4 and level 5 troubles with feeding. And I think the main thing that I want to just stress for everyone is that often we forget that, you know, as practitioners and as clinicians, we often forget that every action has an equal and opposite reaction. I was just so grateful to Isaac for sharing his story, because it really brings home, you know, what we see in the office and what we talk about at work, to say, oh, we'll just try this or try a different bottle, or we're going to, you know, tweak the diet a little bit. How different that is actually when we get home and have to deal with those things personally and with our kids. And I really want to bring that home as well for feeding access, because as a practitioner, I think it's something that we are often fairly quick to suggest, and I don't mean that we don't try everything beforehand, but for us it's like, okay, at least now we'll be able to get some nutrition in, but I do just want to think a little bit about what it means for the family and what it means for them to actually deal with this feeding tube at home, and I'll look at some of the complications as well. So the first thing I wanted to talk about was basically just how we put in these feeding tubes, and Tim probably puts in way more pigs than I do at this stage, but I'll just go through the technique a little bit, because we deal with children with pigs, and we'll often ask for a pig. but there's a difference between a peg and a gastrostomy. And I do also think that sometimes when you have an understanding of how something is put in or the technique behind what you do, then all of a sudden you understand the complications a little bit better, the management strategies and that kind of a thing. So a peg insertion, we normally do under a general anesthetic for children because they're children, so they deserve a general anesthetic for their peg insertion. And often with the children's neurodisability, especially the spastic CPs, we really struggle with their positioning in theatre, and you really have to have a relaxed, completely anesthetized child. The pack for the peg insertion looks like the picture that you see there on the right-hand side, and it usually does come with everything you can possibly imagine. But essentially, the technique of putting in a percutaneous endoscopic gastrostomy, which is the peg, is that we first do a scope with the endoscope. So put the camera into the stomach, we insufflate the stomach just a little bit, but not too much with air, and I'll get into that a little bit later. And we've usually at this stage positioned the child with their head up so that we're using gravity to sort of bring the stomach down as much as possible. So we insufflate the stomach a little bit. If you turn off the lights in theatre, you can often maneuver the camera just so you can see the light popping through the abdominal wall, and that gives you a really good indication of where to place the very large 14-gauge needle that they give you to pierce the abdominal wall with. So that first picture on the upper left is when you're seeing the cannula and the 14-gauge gel coat going through the abdominal wall into the stomach wall. Through that, we take the needle out, and through that we pass the guide wire, which is that blue guide wire that you can see coming through the gel coat cannula, and then you grasp that guide wire, whether it's with another snare or whether it's with biopsy forceps like it is here. We grasp that and then pull all the way out. So we pull it out with the endoscope out of the mouth so that we now have the cannula into the abdominal wall with the guide wire coming all the way out of the mouth. We then tie the peg onto the guide wire that's coming out of the mouth, and we pull it through from the bottom so that the peg then comes down the mouth through the esophagus and pops into the stomach. Obviously, this has its own inherent problems. You can see there, this is a peg, and one of the things I'll get onto on the next slide is that a peg has got a flange. So there's nothing to sort of inflate. It is that size, and you pull that size through the esophagus as well. It is collapsible, so it's obviously not a rigid thing that comes down all the way, but you do have to take that into consideration in children who may have other problems and other difficulty feeding. So children who have had such severe reflux that they have strictures and that kind of a thing. So that's really the technique that we use for placing a percutaneous endoscopic gastrostomy. And that is, you know, stock standard for what we would always want to do. It's the least invasive, it's by far the quickest, and it's got very good results when we use it. The downside to using a peg is that if you do need to change it, which you often do because children grow, is that you need to then remove it. And because it's not a balloon-based structure to hold it in place, it means that people have tried lots of different things. Some people just cut the peg off. I would not recommend that because it can get stuck in the duodenum, and then they wait for it to pass through. Other people, depending on availability to theatre, may use a little bit of conscious sedation and just a real yank of the peg in the side ward, which is horrific, but also unfortunately necessary sometimes when you absolutely have no other option. Ideally, it's great to give proper conscious sedation or to take to theatre to sedate the child, remove the peg, which is still the yanking technique, and then you can place a gastrostomy. So on the next slide, you'll see the difference between a peg and a gastrostomy. And it seems like a silly thing to talk about, but you really need to be able to explain this properly to the parents as well. And not just the parents, but the nursing staff who are involved in looking after these children, the caregivers, because they have fundamental differences that make them either very easy or very difficult to use. So the peg that you see is on the left-hand side, and you'll see what I was talking about with that plastic flange. And that flange doesn't get bigger or smaller. It stays in one shape and one position the entire time. It's really great because it pulls up against the wall of the stomach very nicely. It doesn't leave a lot of gap. They have a lot less leakage than I find, and this is anecdotal, they have less leakage associated with them as opposed to the balloons, because the balloons tend to move a little bit more. And the important thing to note on the peg is that the peg has got only 2 ports at the top. So because of the way that the peg is designed and because of the way that we insert it, there's 1 port for feeding, so that the feeds go through, and there's a 2nd port for medication. That's it. And that makes it pretty user-friendly. So whether you use 1 port for one and another port for the other doesn't really matter. It's going to be a bit more difficult to put your blenderized guide through the medicine port, but you can still do it if you had to. So it's really user-friendly. On the other hand, you have a gastrostomy. So a gastrostomy, a normal balloon gastrostomy, which is what you're seeing in the middle picture. That's the picture from inside the stomach when we see the balloon expanded within the stomach wall, and that's what keeps it in. And you'll see that the gastrostomy has 3 ports. So in the top picture, the 2nd tube, so the one at the bottom of the top picture, does that make sense? Thank you, that's the one. And that has got 3 ports at the top. So one is for feeding, one is for medication, and the other is for a balloon. And if you don't understand, or if your caregiver or the staff that you're working with don't understand and are not familiar with tubes, that balloon port is often mistaken for other things. So medication is put in there, feeds are put in there, the balloons explode, the gastrostomy is dislodged. And if you've taken and you put the gastrostomy in and you've replaced it from a peg, so you've put a peg in and you waited 6 weeks and the tractor is now healed and you want to replace it with a gastrostomy, it's not really that much of a problem. If you've got a gastrostomy that you have placed in the open fashion, so you've actually had to open the abdomen, find the stomach, make a hole in the stomach, stitch it up to the underside of the abdominal wall, and through that procedure, you have placed a gastrostomy. If that balloon bursts and that gastrostomy comes out within the first couple of days or even weeks, it can be an absolute disaster because you can't just pop it back in. It means that you have to go back to theatre to replace things. So often what we'll do, just as a tip and a trick for those of you who do use gastrostomies with people who maybe aren't as familiar with them, is that once I have put a gastrostomy in, I actually tape close the balloon port so that nobody can touch it. And that way you can prevent anyone from accidentally, even a parent at 3 o'clock in the morning, you can prevent anyone from using that port unnecessarily and causing a dislodgement. Then the last thing that I wanted to talk about just from a feeding access point of view is the Mickey button. The Mickey button is exactly the same principle as the gastrostomy, as in it has a balloon at the bottom. But the nice thing about the Mickey button is that it is, its profile is flat. So all of the feeding equipment gets attached to it, but you can take it off and close it off, and that's it. It means that the kids are mobile, they have a lot more freedom, they don't have tubes that are getting pulled on or caught onto things. For those children who like to pull, they're not pulling on things. So a Mickey button is a really, really nice alternative. And if you have access to them, I know we didn't in state for a long time, but now that there is better access to Mickey buttons, they really do make a huge difference to both the family and the patient. So they've got that detachable feeding port, and you'll see that the only thing that you can really put anything or attach anything on that Mickey button is the balloon port itself. Okay. So then a little bit, I think, about the complications. Like I said earlier, every action has an equal and opposite reaction. And I always feel quite pained as a surgeon that when I talk about a surgical procedure, I'll have to say, oh, and the possible complications to this procedure are. But if I was prescribing Panado, you know, you just say, I'm going to give Panado for pain, and you don't necessarily have to go through, these are the side effects, please take out the, you know, the package insert, and also, did you know you can have liver failure? So everything has side effects, and that's what I like to think of from the surgical side as well. So these are some of the complications or side effects to using gastrostomies. And the reason that I've brought this up is not to scare anyone away from using them, but it's because we actually very commonly see complications with gastrostomies in pigs. And they're not to give you a fright, but it's just to help recognize them and also to know that there are treatment strategies for everything. So I've chosen the three most common. The first one is excoriation and leaking. This is a dynamic procedure with dynamic equipment. The stomach is moving, the child is moving, feeds are being put in and taken out, and everything moves with itself. And the same as those people that you see who have stretched their earlobes with their earrings, it's the exact same concept. They didn't do that just over one day. It was just every day using a slightly bigger earring, slightly bigger earring, slightly bigger earring, and eventually they have massive earlobes. And it's exactly the same concept with the peg. The minute that happens, unfortunately, all of that stomach acid leaks out. There's excoriation. The excoriation, once it starts, is very difficult to get on top of. And certainly that's when you need to start employing different measures. So things like your usual barrier creams, for example, zinc castor, may not be adequate to deal with this. And this is when you really want to start going to a gastroenterologist, speaking to somebody in your MDT team, speaking to a surgeon, and finding a way that you can better deal with the ostomy, okay, with the stoma, because that's exactly what it is. So excoriation and leaking are a problem. Once that hole becomes too big, it can be very difficult to get it back down to size. Some of the techniques that we employ are just removing the peg for a couple of days, putting an upsides on and just waiting for it to close down a little bit on its own, and then replacing the peg. Unfortunately, once you've started stretching a peg site, it's quite difficult to not re-stretch the peg site. So it can be a bit frustrating, it can be very difficult, and it is incredibly painful. So it's something that we see in the rooms for 5 minutes, and it's something that really takes up a lot of time for the family and a lot of time for those caring for the child, as well as the child. The second complication is a granuloma and a mucosal prolapse. They can often look very similar. So a granuloma is obviously just an overgrowth of that granulomatous tissue. It's very simple to treat. You can use it. You can treat it with silver nitrate sticks. Sometimes, if it's really bad, we'll even take children to the theatre and just burn it with a diathermy to sort it out. And there are some creams as well and ointments that you can use to try and improve that granulation tissue. It's frustrating because it secretes a little bit of mucus and it secretes a little bit of discharge. And it's when it comes to complications from a gastrostomy site. Mucosal prolapse, on the other hand, is a little bit different. So the mucosal prolapse is when the mucosa of the stomach is prolapsing through that stoma site. And it's far more common in the children that also have VP shunts. So anything with an increased intra-abdominal pressure, so there's a lot of pressure, a lot of straining. Constipation worsens the chances, like Tim was saying, and that's very common in these children as well. VP shunts and coughing from the aspiration. All of these things may lead to mucosal prolapse. It's often misdiagnosed as a granuloma, which means that a lot of people end up putting silver nitrate or trying to burn off the mucosal prolapse, and that is not going to work. So the management for that would be to take the children back to theatre. We cut off the area that has prolapsed, stitch it back together, and hope that it doesn't re-prolapse. And then probably the most feared complication of any peg insertion. So this is only a possibility when you're doing a percutaneous procedure, because you can only see from inside the stomach and from outside the abdomen. Whereas if you were doing this in an open fashion with a laparotomy, it wouldn't be a problem. But essentially the thing that I was talking about at the beginning when I said we position the children with their head up and we inflate the stomach, but not too much, is because it is very common, especially in children who have pliable abdominal walls and, pliable stomachs, that when you inflate the stomach, you actually overinflate it and it pulls up with its mesentery it pulls up the transverse colon. And when the transverse colon is pulled up, it lands up anterior to the stomach. And because you can't see it from inside the stomach or outside the abdomen, the needle that you put in actually goes through the transverse colon first and then into the stomach. And that causes a gastrocolic fistula. These obviously need to be repaired surgically with a laparotomy, and they usually present either with feces coming out of the peg site and also commonly with feeds coming out of the anus. So you'll give the feed and it will come out completely unchanged out of the anus. And those are two of the ways that we sometimes find that there's been displacement or a gastrocolic fistula. Then I had added 1 or 2 slides to my own presentation, which I am mechanically and IT incapable of sharing. But I did want to just mention 1 or 2 things about what Tim had mentioned with gastroesophageal reflux. He'll be pleased to know that I agree with everything that he said, and I don't disagree with anything for 1 bit. I absolutely agree that there is institutional differences. So some institutions will insist on getting a swallow. If your surgeon is insistent on getting a contrast swallow prior to placing a peg, as Tim said, it really isn't necessary we're not doing it to assess for reflux. So if they are asking for it, it's usually to rule out other causes of reflux at the same time. So any anatomical problems, is there an esophageal stricture secondary to reflux? Is there malrotation? And it also gives us an idea sometimes of the size of the colon. So if the children are incredibly constipated, we know that it's something else that we need to just take into account when we're placing the peg, rather than using it for anything in specific. But I totally agree with that. I think the movement is certainly away from getting a standard swallow on every patient who needs a gastrostomy placed. And then the second thing is to Nissen or not to Nissen. And a Nissen fundoplication is a very good operation that can have really wonderful results for people with severe reflux, but it also has a very poor outcome. And it has an even worse outcome in children and in adults who are neurologically impaired. So it's not a one size fits all. And that's one of the reasons why it remains so controversial. Like Tim said, the PPIs are absolutely indicated, and you're not going to lose anything by giving them a trial. And then what we as surgeons generally do before we will consider doing a Nissen is just looking at whether a child has gastroesophageal reflux or whether a child has got gastroesophageal reflux disease. So really, even though we know that a lot of these children are going to be struggling with reflux, we will wait until there are secondary effects of that reflux before offering a Nissen fundoplication. So recurrent otitis media, recurrent respiratory tract infections, dental issues, and severe reflux esophagitis. So often during during the peg insertion, if we do see that the esophagus looks horrible, we'll normally take a biopsy or 2 just to prove that as well. The last point is to bring up that the nasojejunal feeding is really fantastic. And we sort of use it as a screening for whether or not a Nissen will be successful or not. And there's background noise, but it's a generator kicking in, I apologize. So what we normally will do is we'll place a nasojejunal tube. And if the child stops having the symptoms of reflux, that's very loud. If the child stops having the symptoms of reflux and manages with a nasojejunal tube, then we will say, okay, this is a child that may very well respond to a Nissen fundoplication. If you place a nasojejunal tube and you start feeding past the stomach and you find that the child is still having symptoms of reflux, that there's reflux not just from the stomach up, but also from the small bowel into the stomach, then those children are very unlikely to benefit from a Nissen fundoplication. So I hope that's given you some insight into the plumbing related to feeding. It's certainly not the most interesting part of this discussion, but yeah, that's what we generally do.
Thank you so much, Taryn. That was fascinating. We are going to move on swiftly. I we do recognize the time and we apologize if we've gone over time, but this has been a really interesting session, and we hope that you can all stay tuned, because our next speaker is Lucinda Lourens, who is a dietitian who's going to be discussing some of the issues of blenderized versus commercial formulas, and looking at our energy dense and nutrient dense meals for children. So thank you so much, Lucinda. I hand over to you.
Thank you very much. I am just going to put my slides on. Are you guys able to see it? Can you hear me?
Perfect. Yes, we can see and hear.
So I am a registered dietitian. Thank you very much, Jackie. Thank you for this opportunity. I've got a massive passion for neurodisabilities, particularly in cerebral palsy. And to such an extent that the past 5 years, I've actually developed a course for healthcare professionals and do in-depth training on everything from the growth and development to diet-related problems on how we deal with that, and do a lot of practical demonstrations on this. But for today, we're particularly focusing on gastrostomy feeding, a very controversial topic as well when we have to compare blenderized tube feeding to formula tube feeding. I do find that there is a position for each of them. I am in favor of each of them, but it's absolutely the scene and a lot of factors that really you need to take into account on either each of these options that you are choosing at the end of the day. So let me just quickly take you through a bit of background. Initially, this was the only choice. So years and years ago, blenderized tube feeding was the only option. It was made in sterile kitchens and in hospitals, and they found those years ago that blenderized tube feeding was actually not within safety guidelines. And particularly when commercial formulas started in the 1970s, this became the preferred option because commercial formula is easy to use. It was widely available. The labor intensity was low. It had a lower risk of contamination. And if you would compare hanging time, you would either use it as in 24 hours as a continuous feed or as a bolus feed over 8 hours versus 4 hours in blenderized tube feeds that had to be refrigerated, or 2 hours if they weren't refrigerated. So the highest interest and growing number was particularly in the pediatric population because it was affordable. It had a lot of health benefits. If children showed intolerance to a commercial feed, it was easy to switch to blended food. In blended food, you can combine any types of food and food groups and not to worry about the taste. So you could really focus only on nutrients and not worry about how it's going to taste or not. It's a personal preference because particularly if we look at parents that are wanting real food, and we're seeing a trend towards this particularly now in the modern days, and the variety in the diet can be altered in this option. A very big thing that comes up in literature is the fact that it causes improved bowel function. And with children that have severe food allergies, they also tend to prefer this option because they can combine food, particularly for the child that they can actually take in, that they are not allergic for. But if you have to weigh the benefits in physical and emotional health versus the risk, obviously we've seen from Dr. Tim's presentation as well, pureed food may reduce gagging and reflux and relieve constipation, which is a massive benefit. But then the short hanging time or the usage of this is obviously a risk. And then the concerns, particularly from a dietitian point of view, is nutritional adequacy. Does the diet really complete everything? Are we giving enough macro and micronutrients, which are both really important in neurologically impaired children? Possible poor weight gain have been reported. A much slower weight and a much slower growth on blenderized tube feeding has been reported. There's an increasing amount of anecdotal evidence, but I must say there's a lot of articles that have been published last year and this year on blenderized tube feeding that is quite promising. And then the safety. We always query the safety around home prepared meals, especially due to contamination and possible tube blockage if the size of the tube is not adequate. Also, if they don't have the correct resources at home to be able to store the food is also a major concern. Now, if blenderized tube feeds are used, the recommendations are that we need to work closely with the dietitian for an adequate diet. To prepare it safely, you need to look at storage and the administration of the feeds. Flushing the tube with enough water is really, really crucial. And that is also included in the Espen guidelines on peg feeding, that flushing should form part before and after meals. You can do blend rush tube feeding in the day and use a commercial formula at night if this patient is particularly severely malnourished and need to add nutrients throughout the night. Commercial formula can be used together with blend rush tube feeding. So you can mix both in one day if that's a possibility. Food options should not be used that can block the tube. So you need to provide a detailed list for a patient. But I must say, with the heavy duty blenders that we get today, this is usually not a problem anymore. We can really provide quite a substantial amount of food in a diet that won't block the tube due to the fact that they blend it quite well. You can have a commercial formula for emergency situations, especially if you're traveling or things like that, or you maybe don't have enough food or it's spoiled or your resources, for example, your blender has broken, then you've got commercial formula as an emergency. And there are a lot of factors that we need to consider before using blend rush tube feeds. And particularly, I want to focus your attention on an article from Escuro in 2014 and use this as a screening tool in your practice. I'm going to get to that now. Espen in 2017, their position paper said that we need to use blend rush tube feeds with caution and surveillance, because concerns on nutritional accuracy and safety is particularly important. Look at this article from Escuro. I absolutely love using this article as a guideline. Very good resources on here in terms of blend rush feeding options and recipes. She gives a detailed list on the factors that you need to consider before you use the BTF option. You need a medically stable patient. You need a good team. You need a dietitian for support and availability for guidance and direction. Take into consideration the patient and the family must understand good food practices and the importance of cleaning the equipment, etc. The size of the tube is really important. It needs to be more than 14 French. This the gastrostomy tube size has to be matured and healed for no infant, shows no signs of infection. Patient with proven tolerance to bolus feedings is important. The availability of bolus extension, especially for your low profile tubes, are important. And then stable on commercial enteral formula, unless obviously they have a severe intolerance to that. That's another factor to consider. Are they stable or not? Another factor is the patient and the family needs to commit to the time and the effort that it takes to prepare their rush tube feeds. And the ability to follow recipes and instructions are important. They need adequate financial and material resources, like I mentioned, refrigerator, heavy-duty blender. We need good storage containers, clean water supply, food and multivitamins. And obviously a patient with a urinal feeding tube should seek medical permission, because there the diet changes a bit because of the fact that we're bypassing the stomach and certain enzymes that we need, particularly for protein. So when we do jejunal feeding, then the diet changes. So there we need to really be careful. Just to put a picture up of a heavy duty blender called the Vitamix. This particular blender is very, very common overseas, but it's extremely costly. I know of a few heavy duty blenders that can be bought right at Clicks or Discount. So we are fortunate in South Africa to have affordable options for heavy duty blenders. Then Lisa Epp is a dietitian. She gave great ideas on how you can use these recipes. You need for example, 500 calorie recipe with 25 grams of protein. She gave an example there of what you need to add together, blend together, and you give that, provide that then for a child for the day. So she gave nice recipe ideas, and I don't think in South Africa we have something like this. This is really something that the dietitians can focus on. And I do want to raise the concern. Yes, we're looking at calories and protein and they're meeting those particularly, but what about the micronutrients? Are these diets micronutrient complete? For me, micronutrients play an immensely important role in neurodisabilities. So when you do a recipe like this, you need to take into account, is it varied? Does it come from all the food groups and sources, so that we cover the micronutrient status as well? When we look at formula tube feeding, we need to consider that there are 3 types. You get polymeric feeding, which gives you all your nutrients. You get semi-elemental, where the protein is slightly broken down, and then you get elemental, which is quite expensive, and that is an amino acid-based formula, is when the protein has been completely broken down to amino acids. What's nice about formula tube feeds is the fact that you can manipulate the concentration. You can give a 0.5 kilocal as opposed to a 1 or 1.5 kilocal per mole in a feed. So you can manipulate the product and provide it with a certain amount of calories, just taking into account the renal solid load, or particularly pediatric renal solid load. What's nice is you can use it as a ready to use that you can just hang, or provide it in a powder form. You can provide it either continuous or bolus. And then the fiber content for me is extremely important when you choose this option, because of the fact that we know that children with neurodisabilities really struggle with constipation. We still want to get that gut going. So at the end of the day, if we look at the benefits of formula tube feed, it's readily available. It's great for traveling. We know as dietitians what is the precise intake. It's known to us. It's quick and easy to administer. It causes a very low risk for dehydration because you're providing a lot of fluid. It mostly meets the RDA for a patient, but the disadvantages, it can be very costly. Sometimes medical aid can only pay to a certain extent. There's no variety. Parents complain it's a very boring option sometimes, and it can cause social isolation, especially during family meal times. When we look at blend ranch tube feeds, when we use it, we need all those factors that we need to consider. It's a family that's willing to try to commit to the time and effort. It works great for a very severe allergic child or someone that shows intolerance to commercial formula, but this option, you need to be able to comply and work with the dietitian. We don't use it in patients that require continuous feeding. We don't use it in complicated medical and GI problems in a very poor socioeconomic situation where there's compromised conditions, especially if you think of hygienic practices in order to clean all the utensils and the resources. And if there's frequent hospitalization and a child that's frequently sick, also sometimes we really not should consider using this option. And if there's a very small gastrostomy tube size, less than 10 French, we cannot use this option. And that is my story. Thank you very, very much.
Thank you so much, Lucinda. Great. Okay, so thank you to our whole panel of experts who have really given us a very informative session today, just really emphasizing the value of working as a team, especially with children with neurodisability and feeding challenges. We would just like to go back to Isaac, who had initially been our first panel member, because Isaac has someone that he would just like, who wants to say hi to the team today. So Isaac, I don't know if Maayer is ready to say hello to everyone. Okay, I'm not sure if Isaac is having trouble with this.
Hello.
Okay, hi Isaac.
Yes, I'm with you.
Okay, does Maayer want to say hello? Okay. Hello, Maayer. So this is Isaac's little girl, Maayer, who he was presenting earlier on. It's lovely that you could join us as well today, and just really emphasizes the center of our focus when we are discussing our children with these feeding challenges. So thank you, Isaac, for bringing Maayer on. We are really over time, but if there are any urgent questions, please, we can have one or two if anyone wants to unmute themselves or turn their camera on. I know there's been a few questions in the chat group which have been answered so far, so thank you to our experts. Does anyone else have anything else that they would like to ask? Otherwise, we are going to say a very, very big thank you to our amazing panel for their insight, expertise. Thank you to Isaac, especially for sharing your personal story with Maayer, and thank you to Maayer for joining us now. And on behalf of SA Child, we are Wishing you all a wonderful rest of the evening. We will be having our webinar series posted early next year so that you can see what is available each month. So please join us next year for more exciting webinars. Thank you, everyone.
Thank you.